Yeah, madam. Live is started, ma'am. Started, ma'am.
Okay.
Yeah, thank you, ma'am.
So very good afternoon, everybody. I am Dr. Prabhjot. I'm a pediatric neurologist, and we will be talking about approach to neonatal encephalopathy today. I work at KIMS Cuddles, Hyderabad, and I'm happy to take the session on approach to neonatal encephalopathy. So what we'll be covering today is that what is neonatal encephalopathy, how we describe it, what is the definition, and what are the common clinical conditions which can result in neonatal encephalopathy. How do we approach a child who presents to us with clinically with encephalopathy? What is the role of investigation, and how do we manage these children? So what we'll be doing is we'll be going through a few definitions, and then we'll have a few cases, and we'll go on, as we go along. We will see how do we do all these investigations and management. So if we define neonatal encephalopathy, so it is a clinically defined syndrome in which kids who present more than 35 weeks of gestational age in the early days of life, they present with abnormal neurological dysfunction. So this abnormal neurological function can be manifested in the form of subnormal level of consciousness or seizures, which may be accompanied by difficulty with initiating and maintaining respiration and may be associated with depression of tone and reflexes. No, the earliest days of life, it looks a little arbitrary, but it is usually considered up to the first 28 days of life, which is the neonatal period, for kids who are born at or beyond 35 weeks of gestation. Now, this 35 weeks of gestation has been taken as a cutoff point because many believe that before this point of time, there are a lot of other factors which come into play, which may preclude how we examine our kids. The neurological examination may not be that robust. And so the signs of neonatal encephalopathy may not be very strongly picked up. So in kids who are born beyond 35 weeks of gestation, in the first 28 days of life, have presentation in the form of abnormal level of alertness, or they have seizures, which may be accompanied by difficulty with initiating and maintaining respiration. So we may see kids who are unable to maintain their respiration and depression of. Now, this can be due to a variety of etiologies, which include hypoxia and ischemia, metabolic disturbances, or infections. So, these are the case definitions which have been given. And as we know in neonates, sometimes it can be a little challenging to pick up encephalopathy as compared to older kids when it is relatively easy. So, neonatal encephalopathy is many times considered synonymous with HIE, but we need to understand that HIE or hypoxic ischemic encephalopathy has got a definite history of hypoxia or ischemia or HIE, and there is a clear diagnosis. Now, HIE may be a part of neonatal encephalopathy, but it is all neonatal encephalopathies are not going to be HIE. For the term neonatal encephalopathy, it is usually used in a context when we do not know a definite diagnosis at presentation. So kids who do not have HIE are going to be the ones who are going to be evaluated as a neonatal encephalopathy case. So there are a number of etiologies. Like I said, HIE may be a part of your neonatal encephalopathies. A lot of acquired conditions like congenital infections, meningitis, hemorrhage, ischemic or hemorrhagic stroke may present with encephalopathy. A number of genetic syndromes or isolated gene conditions may be the underlying etiology. Neonatal epilepsy syndromes, neurometabolic conditions may be presenting as neonatal encephalopathy. Now, there's a group of disorders which are known as the double pathologies. So, what happens in these cases is that the child does not have the child presents with something like an encephalopathy. So, a child may present with usually HIE, but this HIE is present due to another underlying factor like a neuromuscular disorder or a cardiac disorder. So let us say a child has severe congenital form of SMA. So the child is going to have very low respiratory drive, and because of this low respiratory efforts, the child may end up in a HIE situation. So the child presents with encephalopathy, but the etiology is not primarily related to encephalopathy, it is due to another pathology. And the last is non-accidental injuries. So this should also be considered in kids who neonates present with encephalopathy. So we'll just go through a first case. So this was a 38 weeks appropriate for gestational age baby, 3.1 kg at birth. He was the first born child of a non-consanguineous marriage, had a normal perinatal transition, and presented on day 6 of life with respiratory distress and was referred for ICU. Now, when this child presented to us, the child had respiratory distress, had a weak cry, was placid, and the sensorium was poor. The respiratory efforts were also poor, and for this, the child was mechanically ventilated. The child had septic shock or thought of septic shock at the time of presentation and required inotropic support. So, at this time, we have a child with differential diagnosis of probably late onset neonatal sepsis with shock, probably underlying meningitis or meningoencephalitis, and possible metabolic. So in our scenarios, especially for neonates, sepsis is one of the most common and probably the most properly recognized factor which results in encephalopathy and seizures. So this is something that we have to look up for them for most of the kids who are going to present with encephalopathy. Now this child was investigated further. What we can see that the WBC and the platelet counts are okay. The chest X-ray was showing some diffuse infiltrates. Now, if you look at the blood gas, we can see that there is metabolic acidosis with a normal LFT, a normal CSF, and normal lactates, but the ammonia is again elevated. So the ammonia is for 300. So this child also had hypoglycemia requiring GIR at 8 milligram per kg per minute. The urine results were positive, which tells us that we are not looking at probably a fatty acid oxidation disorder. The NST showed cerebral edema with mildly elevated RIs, and 24 hours culture sensitivity showed a gram-negative growth, and TMS and DCMS was sent, considering that it may be a metabolic disorder considering the high ammonias. Now, our differential diagnosis include late onset neonatal sepsis because we have a culture which is doing something, probably gram-negative sepsis with shock and pneumonia. And probably we have a second diagnosis, which is probably metabolic, likely organic acidemia, because we are seeing a child who is having metabolic acidosis, along with high ammonias. The lactates are normal. Again, lactates may be elevated in kids who have sepsis, but at this point of time, we are probably looking at two diagnoses. So for the hyperammonemia part, the ammonia is in the treatable range, more than 200. So the child was started on sodium benzoate, L-arginine, hydroxycobalamin, carnitine, thiamine, and pyridine. Now, unfortunately for this child, even after the treatment for sepsis and measures to decrease ammonia, the child continued to have persistent metabolic acidosis. The ammonia increased from 350 to 490 to 500. Peritoneal dialysis was initiated, but the ammonia still increased to 1170 micromolar per liter. At this point of time, when we know that the peritoneal dialysis is not working, hemodialysis was planned. But unfortunately, at this point of the time, the family discontinued care because of the high costs as well as the possible associated pneumomorbidity, as well as the acute chances of mortality for this child. So the TMS and GCMS which was sent for this child, revealed that the child had propionic acidemia and the genetics were related. Now this is a very clear-cut upfront case of a child who had hyperammonemia which worsened with metabolic acidosis, giving us a clue that the child has organic acidemia. But what we need to understand here is that the propionic acidemia has been probably precipitated by an underlying sepsis for this child. So how do we approach a child who is presenting with acute encephalopathy? So we do need a detailed antenatal and perinatal history because it clears out a lot of things. We need a good examination, and the labs need to be cleared, and investigations need to be tailored according to the clinical presentation of a child. So how do we approach? So a 3-generation family tree should be made with focus on miscarriages, stillbirths, child or deaths in early adulthood or childhood. Multiple people with cerebral palsy, because then many times it is not just cerebral palsy. It is probably underlying metabolic or genetic disorders which result in neuromotor deficits. People having learning disabilities, seizures, encephalopathy, metabolic conditions. Now, many metabolic conditions which are not presenting with acute life-threatening forms or minor or intermediate forms of metabolic disorders can present with learning difficulties and seizures alone. Early onset ischemic strokes again should be asked for in people, in kids who are presenting with acute onset encephalopathy. Now we'll look at multiple of these points. So multiple miscarriages, stillbirths, or neonatal deaths in the family may lead us to consider genetic thrombophilic disorders or metabolic conditions. Maternal diabetes may result in fetal thrombotic vasculopathy or postnatal hyperglycemia. Deep vein thrombosis or clotting disorders in the mother may be due to thrombophilia or clotting disorder or homocystinemia, which may again result in the child inheriting these conditions. Arterial ischemic strokes again can point towards thrombophilic conditions or vascular abnormalities such as COL4A1 mutations, which can present in neonates with stroke. Now, this can, because these are genetic, they can result in strokes even in the other family members. If the mother has learning difficulties, it may again suggest genetic metabolic disorders, family history of cerebral palsy, can point out towards vascular abnormalities which predispose a person towards having strokes, can be thrombophilic disorders, or even these disorders which result in early brain insults and can present, and the children and later on adults can present only with motor deficits. So family history of cerebral palsy is something that we should always be very, very careful about. Cataracts in the mother can point towards IEMs or myotonic dystrophies or collagen formulations. Excessive stiffness or startling in the mother can point towards underlying myotonic disorders or hyperexia. In a mother who has weakness or muscle fatigue, it can point towards underlying neuromuscular problems like myasthenia gravis or congenital myasthenia syndromes. Now, maternal antibody-positive myasthenia gravis can result in transient weaknesses in the newborn, which can result in a poor respiratory drive, can present with hypoxia and inactivity. Congenital myasthenic syndromes can be inherited to the next generation, and kids may present with recurrent apnea, poor respiratory drive, hypoxia, and again a secondary encephalopathy kind of features. Distal weaknesses of the hand or feet or abnormally shaped toes can point out towards peripheral neuropathy. Now, both these neuromuscular disorders are important because they can cause secondary hypoxia and encephalopathy. Features of autoimmune disorders in the mother can point out towards multiple features of autoimmune disorders like multiple endocrine abnormalities, rash, or other skin abnormalities like Raynaud's phenomenon, eye or kidney abnormalities, muscle aches and pains, heart block can point towards a maternal autoimmune disorder, which can sometimes be transmitted to the next generation also. A common example being neonatal lupus. So again, the history during pregnancy and labor becomes very important. How was the fetal growth on antenatal scans? Were there any fetal abnormalities on the antenatal scans? If at all a fetal MRI was done for any fetal abnormalities, many times kids who have any brain abnormalities will undergo a fetal brain scan to look for or to further delineate these abnormalities. History of multiple pregnancies, which can sometimes result in fetal growth retardation. Maternal infections or carriage of group B streptococcus can point out towards a baby getting inherited, not inherited, a baby getting infected, or a low placental reserve, which can result in poor growth, hypoglycemia in the baby. Maternal hypertension or preeclampsia again can predispose to a small for gestation age baby or can predispose to postnatal low sugar levels, which may be secondary, which I think as neonatologists, most of you must be knowing better than us. Maternal prescribed or illicit drug use, particularly cocaine, can result in growth abnormalities. Illnesses during the pregnancies should be asked for. And HELLP syndrome in mothers, especially associated with acute fatty liver infiltration, may indicate a LCAT deficiency in the baby. Gestational diabetes again is very important because it can result in not only a large for gestational age baby with hyperglycemia, it can also result in a small for gestational age baby due to placental involvement. Any history of trauma during pregnancy, accidental falls or road traffic accidents, or any inflicted injuries should be asked for. Then again, perinatally, we usually ask all these details. Anytime if there was a non-reassuring or abnormal NST, any hemorrhage, placenta previa, or cord prolapse history is present, because these can result in acute ischemia of the baby and can result in HIE. Maternal hypotension or evidence of maternal hemorrhage can again result in an acute ischemic event for the baby. Any non-accidental injury of the baby should be suspected if the baby is presenting following a period of normal consciousness after birth. So examination of the parents again should be targeted to look for any disorders which may be inherited to the baby. It should be targeted to look for neuropathies, myopathies, neuromuscular junction defects, or maternal myopathy. So coming to examination of the newborn, so a detailed examination of the newborn becomes very, very important. We should look at the head circumference abnormalities, any dysmorphism, the shape of the fontanelle, is it any abnormal shape, or how is the size, and is it pulsatile or not? Any rashes which may be suggestive of immune metabolic conditions or clotting disorders, presence of any external or internal ophthalmoplegia, facial weakness, which can point towards neuromuscular disorders or muscular disorders, proximal or distal weaknesses, and we should look for features of spinal involvement, which may be secondary to a difficult vaginal birth. And many times these kids may have mixed upper and low motor neuron findings, bladder retention, and constipation. So all this good examination will help us to narrow down our differential diagnosis in a child who is presenting with encephalopathy. In newborns, there are a few features which may be suggestive of a metabolic condition. These include dysmorphism, micro or macrocephaly, the involvement of the liver in the form of hepatomegaly or raised enzymes, cardiac involvement or in the form of cardiac failure or cardiomyopathy, Iamnomatosis like retinitis pigmentosa, cataracts, cherry spots, optic atrophy or lens dislocation may be seen in multiple genetic inherited IEM disorders. And fetal hydrops, non-immune fetal hydrops, may be an indication for underlying cardiac or non-cardiac conditions and other genetic conditions in which the kids may present with an encephalopathic feature. So whenever we have a child who presents to us with neonatal encephalopathy, we definitely have to review the entire history, examine our child properly, have a family history as well as the maternal history during the pregnancy and labor. If the history and examination is consistent with HIE, we can consider additional investigations like EEG and MRI of the brain. If at all we are not getting a consistent history with HIE, we should go ahead with first-line investigation, which will include CBC, PPINRs, liver and renal functions, infection markers which become very important, CSF, blood sugars, ammonia, lactate, and blood gas, in which we want to look for acidosis, respiratory alkalosis. Beyond this, based on these tests results, as well as how our child is, we can consider second-line investigations. So second-line investigations may include, but are not limited to, neuroimaging, which includes neurosonogram or MRI of the brain, a TMS and a GCMS, metabolic workup, echocardiography, and further testing based on these results. So neonatal encephalopathy can be due to sepsis, which is a very common differential. Low HB may indicate low HB and ICH1 neurosonogram may present with encephalopathy. There can be signs of raised ICP. So if you have a low HB and there are signs of raised ICP, we should consider meningoencephalitis, large intracranial hemorrhage, large infarcts, or congenital tumors. It is important because many of these kids might need an urgent neurosurgical intervention. Evaluation for hypotonia and contractures. We should consider double pathologies like neuromuscular disorders or high cervical trauma, especially with risk areas in kids who have hypotonia and contractures. In such cases, we should go ahead and do CPK, electromyography, or MRI scanning as needed. If the examination findings are consistent with IEMs, we should go ahead with the IEM workup. Epilepsy, again, we know. In cases of neonatal epilepsies which present with encephalopathy, so in many epilepsies, the kids will be normal in between seizures, in which case they do not have encephalopathy. Many kids who have continuous or multiple seizures may become encephalopathic once these seizures start. So in these conditions, we should consider vitamin-responsive epilepsies because these set of epilepsies are responsive to vitamins and they are treatable cause of neonatal and infantile epilepsies. We need to consider structural brain malformations, non-ketotic hypoglycemia, glucose deficiency, sulfide oxidase, molybdenum cofactor deficiency, and peroxisomal disorders in kids who present with epilepsy and encephalopathy in the neonatal period. Other etiologies may include structural brainstem abnormalities in which there may be a poor respiratory drive, which is central. Presence of other abnormalities like ascites or congenital lung disease or cardiac disease may result in hypoxia and secondary encephalopathy. So once we have considered the early causes of encephalopathy, and beyond that we are considering inborn errors of metabolism, we can have a group of kids who will present to us with metabolic acidosis. In this, we see if you are looking at high iron metabolic acidosis, and is it explained by sepsis, hypoxia, bowel ischemia, dehydration, or poor perfusion. If it is not explained by these conditions, then we should look for lactate. If the lactates are elevated, we should consider organic acidurias and mitochondrial disorders. Organic acidurias may have associated elevated ammonias also. In cases of elevated lactate, if it is associated with persistent hypoglycemia, in addition to elevated lactate, we can consider disorders of fatty acid oxidation, organic acidemias, or glycogen storage disorders. In cases with normal lactate, we should consider organic acidemias. These might have associated elevated ammonias. Many times lactates may be elevated. Many times lactates may not be elevated. So we should understand that elevated lactates are a marker of anaerobic oxidation, and hence we can see in elevated lactates in disorders in which the normal metabolism is not taking place and anaerobic metabolism is dominating. In case we have a set of kids who have elevated lactates and the organic acid profile of the TMS, GCMS are normal, we need to consider mitochondrial disorders which can present in the neonatal period with elevated lactate, which include pyruvate dehydrogenase deficiency, pyruvate dehydrogenase carboxylase deficiency, and respiratory changes. On the other hand, if we have metabolic acidosis, which is not either the metabolic acidosis is absent or it resolves quickly, and then we have to look for further handles. Now, if it is associated with persistent hypoglycemia, without acidosis, we look at the ketones. If the ketones are low and the free fatty acids are raised, we look at the fatty acid oxidation disorders or disorders in the carnitine pathway. If the ketones are low and the free fatty acids are also low, then we can look at disorders in which hyperinsulinism may be present. In cases of elevated ammonia, we have the ammonia, the urea cycle defects, the HHH, which is hyperacetolemia, hyperammonemia, hypoalbuminemia syndrome, and hyperinsulinemia, hyperammonemia syndrome can present with isolated elevated ammonia. In cases of kids who have normal sugars as well as normal ammonia, we should consider peroxisomal disorders and glycosylation disorders. Peroxisomal disorders usually present with dysmorphism, skeletal abnormalities, hepatomegaly, cataracts, or retinitis pigmentosa in the baby. Glycosylation disorders may have variable involvement. The kids may be floppy, they may have inverted nipples, they may have abnormal fat pads, and transferrin isoelectric focusing is a test which is helpful for narrowing down on diagnosis-based disorders. In cases where we do not have any handles in the initial investigations, which can help us to identify the etiology, we can consider either genetic epilepsy syndromes, in which the epilepsy is a refractory epilepsy type, unknown IEMs, it may be a genetic syndromes, which may be monogenic or deletion duplications, and it sometimes may be an atypical presentation of HIE. Genetic testing should be considered in most of the cases in which we are not sure it is HIE, and we are considering an underlying genetic abnormality. So let us look at this next case. So this was a 10-day-old baby. So in the next few cases, we are going to apply whatever we have just read. So this was a 10-day-old baby, a female baby, presented with multiple episodes of abnormal posturing, cycling movements of the limbs, and arching of the back. So this was a 39-week baby who was 2.9 kg at birth, cried immediately after birth, and had good APGAR scores. The baby had a normal perinatal transition, had a normal antenatal history, and the parents have a non-consanguineous marriage, have married. Prior to referral, the baby received levetiracetam up to 40, phenobarbital up to 3, and was referred in view of persisting seizures. The baby also had a normal PDINR and factor SA, which was done prior to referral. Now, if you look at the paternal and the family history, there were no previous abortions or intrauterine deaths. The maternal grandmother had history of varicose veins and pulmonary embolism. Maternal sister had postpartum hemorrhage requiring multiple blood transfusions. So at the time of admission, the baby had altered mental status with no spontaneous eye opening and poor pain responses. The baby had intermittent cyclical movements of both the upper and lower limbs. The AF was full. The pupil was bilaterally equal and reactive to light. The tone was decreased in both the upper limbs and lower limbs with exaggerated reflexes. Now, full AF, which is not pulsatile, with low tone and hyperreflexia, may indicate towards signs of raised ICP. So in this child, we were considering, so we have a child who is presented to us with status epilepticus, has signs of raised ICP. So we are looking at possible intracranial hemorrhage. But what is the etiology of this intracranial hemorrhage? So when the baby came to us, we had active seizures. The levetiracetam was increased to 60, phenobarbital was continued at 3, and phosphonated was added. The child was started on neuroprotective measures. For that, the child was intubated and raised anti-edema measures were started. Bedside ultrasound revealed that the baby had intraventricular hemorrhage in both the hemispheres, in both the lateral ventricles, which was extending into the third ventricle. So the CECT was done, which showed a grade 3 ICH in both the lateral ventricles, the third ventricle, and the fourth ventricle with hydrocephalus. And we did not find any features which were suggestive of a CSVT, because as we know, cerebral synovenous thrombosis can present with an active intracranial in babies. The EEG was done, which showed near continuous discharges, which were right temporal predominant, and normal background was absent. So considering that we have a child with status and the EEG showing continuous discharges, the child was started on midazolam infusion, which was continued for 36 hours. So initially, on the basis of EEG monitoring, the midazolam was tapered. The child was put on continuous EEG monitoring, and the child at this point of time was on Levodopa, was on phenobarbital and phosphonatoid. The child continued to be on mechanical ventilation. So after the 4th day, over the next 36 hours of midazolam infusion, we saw a decrease in the right temporal discharges, and normal activity was starting to appear in the bursts of activity. And by day 4, we had a normal background activity with the decrease in epilepticon discharges. So as there were no clinical seizures beyond the 4th day, after the day 4, the phenobarbital was tapered and stopped. And by day 8, we had stopped both phenobarbital and phenytoin, and the child was continued only on levetiracetam. The child was extubated and was on Zuvia by day 30. So the MRI of this child revealed bilateral lateral ventricles showing bleed, which is extending into the third ventricle and the fourth ventricle. What we can also see that the cerebral white matter, so these are diffusion weighted images. We can see that the corpus callosum is white, and some areas which are adjacent white matter areas to the ventricles are also white, which show that there is an active diffusion restriction, which means that there is cytotoxicity. So some pressure effect and edema of the associated overlying white matter also was present. An angiogram was done because AV malformations to become an important differential diagnosis who present it with in a child is presenting with a massive intracranial bleed without any predisposing factor. So we must remember that we do not expect such a big bleed to happen in a term bleed. For preterms, yes, it can be affected, it can be expected, but for term babies, it should not happen. The angiogram was predominantly normal, but what we can see is that the large bleed is kind of including a major portion of the angiogram. So it means that we need to repeat the scan after 6 to 12 weeks to actually see whether we are having any AV malformation. So this child was extensively worked up for bleeding etiologies. They were all negative, including the detailed factor assays and genetic testing. So final diagnosis for this baby was a neonatal hemorrhagic stroke. So neonatal strokes are, or neonatal hemorrhagic stroke is a bleed which is happening in a term baby, is termed as a neonatal hemorrhagic stroke. And we do work up for all neonatal hemorrhagic strokes. And for this child, we did not find any etiology. And as we know that the chances of finding an etiology of neonatal hemorrhagic stroke are also less, and the recurrence is also less than 1%. So this was a child who presented with encephalopathy. What the ultimate understanding and what the ultimate understanding from this case is that a child who is presenting with seizures and encephalopathy turned out to have an underlying hemorrhagic stroke. So this, the next baby, so this was a 39 weeks baby, again appropriate for gestational age, and a vacuum-assisted delivery. This child apparently cried immediately after birth is the history that we want. The APGAR scores were not available and the parents were non-consanguineously married. So this child had normal academic behavior, but immediately after birth had some amount of respiratory distress, was shifted to the NICU and was on oxygen support for 3 days. Now the child had culture negative sepsis. The sepsis screen was positive and the platelet counts were low, and the persistent lethargy persisted till day of life. Day of life 5. On the day of life 5, the child had 2 episodes of left focal seizures, for which the child was loaded with Levipil followed by phenobarbital and subsequently was referred. Now, when we saw this child, the child had tachypnea, the child had a poor cry, tone and activity, had depressed newborn reflexes, and there was a right parietal cephalic. Now we have a child who is a term baby, and our differentials are probably sepsis or meningitis, because this screen is positive. It might be an intracranial hemorrhage, or it might be a neonatal stroke, which may be AIS or hemorrhagic stroke. For any child who presents with focal seizures, acute ischemic stroke has to be one of the differentials. So it was kept as one of the differentials. Now, the child was on HFNC oxygen support at our center. The chest X's were normal. After the third seizure, after admission, the child's Levipil was increased, following which the seizures were passive. The CSF was okay and the EEG was showing right frontal discharges. Neosonogram was normal. The newborn screening was negative. Ammonia lactates were normal. Blood culture sensitivity showed Klebsiella pneumoniae, it grew Klebsiella pneumoniae. And by day 3 of life, the synsomnia was better. Now we have a child who has an apparently normal perinatal transition, has persistent respiratory distress, and later on develops a seizure. And now the cultures are also positive. So by day 3 of admission, the sensorium was better, the cry activity improved, the neonatal reflexes improved, and MRI was done, because still we are not very sure of the cause of the seizures. Now, interestingly, the MRI of this child showed, now again these are the diffusion images. What we are seeing is that the posterior white matter, the corpus callosum, and the periventricular white matter, the posterior limbs of the internal capsule, and the thalami, they all are showing acute cytotoxic edema. It is extending up into the watershed watershed areas, we are seeing again cytotoxic which is extending up to the high frontal and parental areas. So we are seeing watershed area infarcts and we are seeing thalamic involvement also. So watershed area infarcts usually are indicative of an acute deficiency in the blood supply to the brain. Thalamic involvement is usually indicative of a hypoxic ischemic injury. So there was mild to moderate ischemia which had happened for this child, and the final diagnosis was again HIE stage 2 with neonatal seizures and culture positive sepsis. Now again, we have to be very careful in the way we are taking history. Again, this child's imaging is what helped us to the final diagnosis. And as we can see that we did end up doing a lot complete metabolic workup for this child, because many times if the history is not upfront coming about HIE, it may be confusing whether we are looking at HIE or are we looking at any genetic metabolic disorders. So for this child, the imaging was consistent and the screening was negative. So we did not do any further investigations, and this child is doing well on follow-up. So again, HIE can be a confounder. A good history and examination becomes very, very important. Now this next child, this was a preterm baby, 35 weeks, and was appropriate for gestational age, had a meconium aspiration at birth, had respiratory distress requiring CPAP support. Now at 36 hours of life, this child developed seizures for which he received levetiracetam and phenobarbital and was seizure-free for the next 7 days. Now the next 7 days after the onset of seizures, he was off CPAP, direct breastfeeding was initiated, the activity was good, and the baby was discharged. Now the baby is okay for 1 week at home. On day of day 15, he starts to have recurrent seizures in the form of 3 to 4 episodes of seizures for which the levetiracetam was increased. Now the clinical seizures were controlled, but the child continued to have a poor activity, decreased spontaneous motor movements, and more. Now the seizures are controlled. Now something which started as seizures is continuing as encephalopathy, and the child was referred for worsening of encephalopathy on day 18 of life. So he was in this situation for 3 days, beyond which he was referred to us. At this time, the child has kind of okay heart respiratory rates. The child was hemodynamically stable. The BPs are okay. The efforts were good, but the child had a poor cry, poor tone, and the neonatal reflexes were depressed, and the child had a poor suck. Now, if you look at the database, we have a late preterm baby, has meconium aspiration and has respiratory distress, and has neonatal seizures, which were probably HIE stage 2. Now, the differentials we can consider at this point of time as initially had HIE-related seizures. Now, does the child have late onset neonatal sepsis with meningitis when the child has presented again with seizures on day 15 of life? Is it secondary to a structural insult due to the initial HIE which happened? So, a child who is having HIE may have structural insult to the brain, which can result in seizures later on. Or are we looking at a metabolic etiology because the child has an interval of being well after which the child has worsened? Is it a vitamin responsive epilepsy or a genetic epilepsy? Many of the genetic epilepsies can present with epilepsy with worsening encephalopathy, falling into the group of epilepsies which were earlier known as epileptic encephalopathies and are now known as developmental epileptic encephalopathies. So again, this child. For this child, we planned investigation workup and we did an EEG, and neuroimaging was planned upfront, and further workup we planned on the basis of neuroimaging if you want to go ahead with metabolic or genetic workup. This child was initiated on NG tube feeds, the CPAP was continued, and but the child had recurrence of seizures 24 hours after admission, which required him to be put on mechanical ventilation. So the initial labs for the child showed a normal WBC count, HbA platelets. The chest X-ray was consistent with RDS with primarily diffuse infiltrates. The ABG, LFTs, CSF was normal. NST was showing only mild cerebral edema with periventricular flare, but the EEG was showing an encephalopathic background with burst suppression. Now, if you look at the entire thing, the rest of the investigations are kind of fine, but the EEG is not supporting. So EEG is showing an unfavorable background. So this is what we saw in the EEG. So this is a 35-week baby who has come to us at 2 weeks of life. So the corrected gestation age of 37 weeks. So for 37 weeks EEG, we are seeing that the child has abnormal bursts, which are showing 150 to 200 microvolt background. We are seeing some spikes and sharps. The interburst interval is long. It is 10 to 12 seconds, and the amplitude is less than 10 microvolt. So whenever we look at neonatal EEGs, we have to correlate the EEG findings with the gestational age or the corrected gestation age for the baby. baby. So for the 37-week baby, an IBI or the inter-burst interval, which is the interval between two bursts, is long. What we expect is something 6 seconds or less than 6 seconds, and the amplitude was also low. So what we are seeing is a burst suppression pattern. What we also see in the bursts is that we are seeing certain abnormal activities in the bursts as well. So now we have a child who has burst suppression pattern, has epilepsy and encephalopathy, which has presented in more than 15 days after birth, and we have negative sepsis markers. So we went ahead and did all the neurometabolic marker. So the RBS was normal, ammonia lactates were normal. IV pyridoxine was given with EEG monitoring. Considering vitamin responsive epilepsies, there was no significant immediate changes in the EEG. TMS and GCMS was sent. Pyridoxine cholinergic acid was added for vitamin responsive epilepsies. Hydroxychloroquine and thiamine was added for suspected metabolic disorders. Now for this child, the MRI played with MRS was again normal. The TMS was normal, the GCMS was normal. We repeated an EEG after 5 days. Now at this point, the baby has not had any further seizures. What we can see that the EEG background is significantly better. We can appreciate that the amplitudes look better here than what they looked on the previous EEG. The EEG activity in the bursts also looks normal. We are not seeing any abnormal activities. The EEG is also started to become more continuous. So the amplitudes are better and the activity is better, which overall suggests that the encephalopathy is improved. We are seeing age-appropriate markers in the EEG. So there was no seizure recurrence for the next 2 weeks. The sensorium gradually improved and the child was shifted to paradigm peace. The child had required a prolonged respiratory support post-extubation, and at present has ongoing oxygen requirement. The chest X-ray did have a pneumonia and antibiotics were continued. The child had a normal examination, neurological examination at discharge, and we are waiting for the child. Now, the discharge diagnosis for this child is likely genetic epileptic encephalopathy with very vitamin responsive epilepsies, because we did add multiple vitamins for the child's epilepsy, although we did not see any acute response to pyridoxine, or it may be a metabolic epilepsy. So we might still be looking at a metabolic disorder which has responded to the supportive care. So again, sometimes the diagnosis is not very clear upfront. Our screening tests may not give us the answer, and we have to rely on genetic diagnosis to give us an answer. And again, many times even the genetics may not pick up the abnormality. So sometimes it's not very straightforward. It is not very easy to diagnose a child who's presenting with epileptic encephalopathy. Now, if you look at the management of a child who presents with encephalopathy, supportive care is of the utmost important. Whatever is the underlying etiology, whether it is an IEM, whether it is organic acidemia, whether it's a urea cycle defect, whether it is an epilepsy, supportive care is what is going to pull our child out. So we need to be very aggressive with the neuroprotective measures. In cases of raised intracranial pressures, we have to manage intracranial pressures aggressively. Even in neonates, sometimes very large breeds may require neurosurgical interventions. So it should not be considered that it is a neonate and AF is over. So neurosurgical intervention should not be done. It should be done if needed, and it does change the outcomes. So seizures require excessive control, and the associated things which can result in these factors, or sometimes that are associated as an independent factor, like sepsis, shock, gut issues, hyperglycemia, have to be aggressively controlled, because these are the things which are going to add to morbidity and mortality for his kids. So if you have a child who has organic acidemia but has a severe hypoglycemia, organic acidemia may be controlled after a few days, but hypoglycemia can result in permanent structural brain malformation. So that is why supportive care and aggressive control of all these factors is extremely, extremely important. Treatable etiologies always take precedence. So sepsis is the most common in our setting, so it is always correct to work up for, and in neonates presumptively treat for sepsis. Whenever we have a child who is presenting with encephalopathy, we can always and should always downgrade our antibiotics in case sepsis is proved to be not present. Okay, so neuroimaging again gives very important clues. HIE, like we saw in one of our cases, can be picked up on neuroimaging even if the history is not consistent. CNS infections like viral congenital infections can again have MRI clues. Venous thrombosis, ICH, and strokes can picked up on neuroimaging. Metabolic disorders like mitochondrial disorders, biotin basal ganglia disease, PDH and PDC deficiency, which are mitochondrial disorders, peroxisomal disorders, and organic dysrhythmias can have consistent abnormalities on the MRI, which can help us to narrow down and tailor further investigation. In certain kids, structural abnormalities can be seen on imaging, especially if the kids present with epilepsy or certain metabolic disorders. Certain metabolic disorders like PDH and PBC do have structural brain abnormalities also. So imaging is always complementary to our clinical acumen, but then it has to be tailored and investigations have to be done on a case-to-case basis. Screening investigations, when done early, do guide our management. Specific treatment for hyperammonemia, hypoglycemia becomes very, very important, which we get on the screening investigations. Empirical megadose of vitamins may help in management. Once we are not very sure what are we looking at, and if we are suspecting IEMs or vitamin responsive epilepsies, we should start our neonates on hydroxycobalamin, thiamine, biotin, carnitine, and vitamins for vitamin responsive epilepsies. Now, this is the last case. So, this was a 36 weeks baby who was appropriate for gestational age, apparently had a normal transition, and on day two of life had multiple episodes of seizures and was loaded with levodopa 2 doses per day. Now, in view of dull baby with poor responsiveness and shadow efforts, the child was mechanically ventilated and referred to us. Now, this child at admission had respiratory distress, had respiratory rates of 92 per minute, low saturations. The sugars were normal, and the poor cry and pain response was poor, and the cry was also poor. So, our neonatologists went ahead and we were considering differential diagnosis like metabolic disorders, hypoglycemia, hypomagnesemia, low sugar related, early onset neonatal sepsis, meningitis, or an IEM in a child who was presented with seizures followed by encephalopathy. Now, our neonatologists went ahead because the child is mechanically ventilated, has respiratory distress, is not maintaining saturation, and X-ray was done. So what we see in the X-ray is that there is entire whiteout of one side of the lung. The mediastinum seems to be shifted towards the right side. So this child had right-sided, right-sided pneumothorax. I'm so sorry. We can see the pneumothorax on the right side, and the left side of the lung is completely whitened. So this child had a right-sided pneumothorax. The calciums were low, sepsis screen was negative, and CSF was normal, and ET was normal for age. 24 hours admission, the child was extubated, the sensory was better. There was no seizure recurrence, although the culture reports were admitted. Now, this child had hypocalcemic seizures, which might have caused the seizures, and the child also had pneumothorax, which most likely resulted in hypoxia and resulted in seizures. So again, the message in this case is that not every neonatal encephalopathy has to be sinister. Common things are still common. So in any child who presents with neonatal encephalopathy, we need not jump over the high-end tests upfront. What we need to do is follow our routine metabolic screening tests like calcium, sugar, magnesium first before we go on to other investigations. So I will conclude by saying that not all neonatal encephalopathies are HIEs. We should investigate when there is no clear history available of HIE. We should use our investigations judicially. Each and every investigation has to be tailored for our babies. Beyond the first line investigations, neuroimaging gives us important handles to evaluate and try to come to a final diagnosis. Supportive care is extremely, extremely important for all the babies to prevent mortality as well as decrease the neuromorbidity for this child. We should try to establish diagnosis in all cases, although it may not always be possible, but we should still put in that effort. So that was all. Thank you for your patient listening. And if there are any questions, you can leave that in the comments and we will get back. Thank you. Stop. Stop here again.